My name is Tiffany Townsend. I'm a neurologist who specializes in epilepsy, like Elvira said. And I have sort of, by default, sort of had to do this topic several times, but I'm actually getting more and more interested in it. And there are a lot of aspects to women's healthcare and epilepsy. So there's actually quite a lot of material that one could cover. So I'm going to try and break it down into different stages of the life cycle, let's put it that way. And so different issues will come up as a woman is aging. So around adolescence, puberty, there are specific issues around menstruation, specific psychosocial issues that come up when you're a teenager, and just about how to manage your epilepsy on your own and transitioning from sort of childhood, being a child and having your parents kind of manage everything, to being in charge of your own health. Then the issue of pregnancy comes up, and pre-pregnancy planning, as well as how to manage epilepsy during pregnancy, and then postpartum issues such as breastfeeding and childcare, etc. And then later in life, through menopause, there's issues of seizure control, as well as this topic about bone health and the risk of osteoporosis that may be associated with certain anticonvulsant medications. So I'll try and go through all of this, but it's a lot. Some topics I'll go over faster than others. Pregnancy, usually there's a lot of issues around that and a lot of questions around that. But feel free to sort of ask questions, even if you're really confused about something while I'm talking, just raise your hand anyway, because I could maybe clarify instead of waiting till the end if you want. We'll see how it goes. So for adolescence, there's a few issues that come up in terms of growth. There's questions about whether or not epilepsy itself or the medication you're taking might affect either your growth, your weight, lipid metabolism, which means basically cholesterol and fatty acids in the blood, and then fertility issues. So there has been some research done into whether or not if a child has been on anticonvulsants during childhood, pre-puberty, whether or not this affects their long-term growth and health. And it looks like if a child comes off the medications before going into puberty, then really there's not much evidence that there's any long-term health effects of that medication. There have been a few studies that show that very small children on certain anticonvulsants could have high cholesterol just when they're very young while they're on it, but this resolves and goes away later on, even if they're on the medication, and definitely by adulthood that would be gone if the child had stopped the medications. In terms of growth rates for children, for females that have been on anticonvulsants in adolescence, it doesn't seem like there's any big difference between the height of females that have been treated with anticonvulsants during adolescence and those who have not. So it doesn't seem to have any adverse effects on growth. In terms of weight, it does seem that if a child has been started on certain anticonvulsants, specifically valproic acid, and then continues on this medication into adulthood, then there is an increased rate of obesity, dyslipidemia, that just means like high cholesterol issues, polycystic ovary syndrome, that's what this means, which I will explain in detail later what that is, as well as hyperinsulinemia, which basically is sort of a pre-diabetic state, so type 2 diabetic, pre-diabetic state. So there are increased risks for these things. It doesn't mean for sure it would happen, but this is the medication that would give you that risk if it started in childhood and continued on into adulthood. And as we go through this talk, there's going to be a lot of issues with this medication, valproic acid. It sort of has a lot of things going against it lately, so it'll be a bit of a recurring theme as we proceed. During adolescence, there's questions of whether or not seizure control will change. So as you go through puberty, there's a potential with different hormones fluctuating that seizure control could change. So it's very unpredictable, however. So some people, their seizures might get a lot better after puberty. Other people, their seizures might just start after puberty, and some people experience no change whatsoever. So it's difficult to predict who is going to be affected adversely by going into adolescence or who's going to improve, except for, say, this one specific type of epilepsy, childhood absence, which usually people will get age 9-ish around. Often they will grow out of that by the time they're a teenage year. So that's a very specific kind of epilepsy, which in a way is positively affected by going through puberty. But the rest of the types of epilepsy, there's not really much in terms of predicting, who's going to get worse and who's going to get better. Also, as you may just transiently worsen. So as you're going through puberty, the seizures might get worse. And then after you pass through and the hormones settle down again, things might settle down again with the seizures as well. So it could be just a transient thing. Also, as you're getting older and going through teenage years, medication doses might need to be adjusted because you're growing and getting bigger, and you might need more in your system to reach the same level. So there could be changes in seizure frequency relating to that. Like all of a sudden you've grown and the medication's really low in your system now and you need more. Other issues that come up during adolescence, this is girls and guys, would be the transition, as I had said before, from dependence, sort of being the child, to becoming, you're the adult in charge of your own care. So it's an important time for patients or people with epilepsy to sort of try and take charge of their own health. So they start coming to my clinic, say from the children's, the mom or the dad usually still has the medication list, and they sort of take the prescription, and the patient, who's now the adult, still sort of sits there a bit like the child. So it's a bit of a hard transition to get the roles to change a bit, but it's important for your own seizure control to sort of take charge of your own health at this stage when you're in the late teens, to sort of try and take over being in charge of your medications, knowing your doses, taking control of keeping track of how many seizures you have, because in the end, you're the one who's going to have to manage it. Sleep is a big issue in adolescence because often teenagers, want to go out and stay up late, and that's normal, and stay over with friends and everything. But this could also adversely affect the seizures. The same with experimenting with alcohol and drugs, and maybe there could be issues with non-compliance and not taking your medications on time and missing your medications because you're going out with friends, you don't have a regular schedule. So I'm just listing all these things, but really it's just to bring up things that come up during adolescence that make it more difficult to manage the epilepsy. But they're all things that everyone has to go through in terms of just learning to see, how it's almost like testing boundaries, like how much sleep do I really need before my seizures go crazy, or how many medication doses could I miss until this. Everyone sort of has to go through this testing phase. So everyone's going to go through it, but it's just to sort of list that these things do come up during adolescence, and for women and for men. And it's just to sort of make note of that these will be coming up during that time of life. Okay, so now I'll move on to the menstrual cycle. So first I'll go over the normal menstrual cycle and the hormone fluctuations during that. And then I'll try and explain how that can affect seizures, because certain hormones have certain effects on your brain's tendency to have a seizure. So I'll go into this in more detail. So the normal menstrual cycle is about 24 to 35 days long. Usual is around 28 is sort of the classic time frame that we hear. And for the purpose of describing this, day 1 is considered, of the cycle, is considered when the menstruation starts, the bleeding starts. And day 14 is usually when, average when ovulation occurs, but this can vary quite greatly from person to person. So this is just a diagram to explain the hormonal fluctuations during the menstrual cycle. So first, here we are, day 1. So this is different hormones, okay? So this is hormones that are secreted from your brain, basically from the pituitary gland. This hormone is called follicle stimulating hormone. and it is released from the pituitary, and it stimulates the ovaries to produce estrogen. And the estrogen, the buildup of the estrogen, is what allows the egg in the ovary to mature to the point that it's going to get released at ovulation. So during the first half of the cycle, from day 1 to usually around 14, the days are written down here, there's a buildup of estrogen to the point where then the egg gets released. And at that point, there's a big drop in estrogen. And then as the egg travels down the fallopian tube, it's called the corpus luteum, then if it doesn't get fertilized, then it releases progesterone. So progesterone is building up during the second half of the menstrual cycle. And if the egg doesn't get fertilized, then this corpus luteum then kind of just degrades, and then the progesterone drops, and then you get the bleeding of the menstrual cycle. So during the progesterone phase, the uterine wall kind of builds up during that phase. And then when the progesterone drops, that's when it's sloughed off and you get the bleeding. So there's two big fluctuations. So there's the estrogen buildup and the drop of that around day 14, around ovulation. Then the buildup of progesterone and the drop of that just before the bleeding. So this will be significant. So I will explain. So when you think of epilepsy in the menstrual cycle, there's sort of two different things. Either the seizure frequency can change depending on which part of the cycle you're in. So some people really have seizures that seem to happen always around the time of the menstrual cycle or always around the time of ovulation, or both. And when someone has a very regular pattern like that, there's a name for it, and it's called catamenial epilepsy. And this just means monthly. I think I have the exact Greek term it came from in another slide. And then the other thing is that the menstrual cycle itself could become disordered by your epilepsy or the anti-epileptic medications. So people with epilepsy can have more problems with not having cycles where they don't ovulate, can get polycystic ovary syndrome, or premature menopause. So there's sort of two ways in which epilepsy and the menstrual cycle can interact. So for the first one is people who have the epilepsy that's really related to different times of the menstrual cycle, the catamenial epilepsy. So usually people say that it happens around the time of the menstrual cycle, less likely ovulation. Most people sort of say there's a relationship, but I find that when people actually document it out, it often isn't as strict or reliable a relationship as someone might think it is. But it's very important, I think, to document it, because if you do have a very stereotyped relationship, like it's always around 2 days before the first day of the menstrual cycle, this could be useful because it may help us figure out a way to adjust your medications to try and help with the seizure control. So relating back to these hormonal fluctuations that I was talking about, estrogen lowers the seizure threshold. So estrogen makes you more likely to have a seizure in relative terms. I mean, everyone has estrogen who's a woman in this room, and we're not all having seizures, so it's fluctuations in the hormones. So when you have relatively more estrogen in your system, your brain is slightly more likely to have a seizure. And when you have more progesterone in your system, you're slightly less likely to have a seizure. So it's a little bit of an anticonvulsant, the progesterone. So back to this diagram. So during this time when you have the most estrogen in your system around ovulation, that could be a time when you're a little bit more vulnerable to having a seizure, because estrogen is a little bit more pro-convulsant. And then the progesterone part, so after ovulation and sort of the buildup of progesterone, during that time you're sort of relatively safer, almost a little bit more protected from a seizure. And then when the progesterone drops off right before the menstrual cycle, then you're a little bit more vulnerable again to having a seizure, because the progesterone was a bit protective, and now there's a big drop in it. So your brain is a little bit more vulnerable at that time. So these are the reasons why people think, the researchers believe, that when the ovulation period and the time of the menstrual cycle are the times when people tend to notice that they have more seizures. That's what many women report. And some women seem to be more sensitive in terms to the estrogen, the ones who have their seizures more around the ovulation cycle, and the ones who have them more around the menses, it seems like they're more sensitive to the fact that this progesterone has dropped suddenly. So the progesterone kind of works more for them to protect them from seizures. Yeah, so I already explained this, okay. So as I've said again, so it's usually around ovulation or just before the menstrual cycle when the progesterone's dropping that people usually have seizures. And what's interesting is that women with epilepsy tend to have more cycles where they don't ovulate. Now this could be because of seizures themselves, or it could be because of certain effects of some medications. But when studies have been done kind of measuring, following women and measuring hormones in their system to know if they ovulated during a specific cycle or not, it looks like the seizures are more likely to happen during a cycle where you didn't ovulate. And one of the reasons for this is thought that because you don't ovulate, then you don't get this whole corpus luteum producing the progesterone and getting this bigger progesterone buildup. So you have actually less of this progesterone time. So then maybe during that time you're more vulnerable to having seizures because the progesterone sort of protects you a bit from having seizures. Does anyone have any major questions there? Like, I know this is a little bit hard, but okay, well, anyone can ask later. Okay, let me go back. Sorry, I went the wrong way. Right, so in order to diagnose catamenial epilepsy, like I was saying, it's important to try and keep a seizure diary and a diary of your menstrual cycle to see if there really does seem to be a relationship there. That's the first step. And then if there is, then we try and figure out, is it really around the menstrual part or around the ovulation part? And then you can sort of target the medications that may help you to the time during the cycle where you're more vulnerable to having seizures. So some people might add in some other medications. Clobazam is usually a more popular one to kind of put in for a few days and then take out again. So kind of add it in around the time where you seem to tend to have more seizures. And sometimes that does the trick. Other times it seems for people who perhaps have more of these anovulatory cycles, if you add in some progesterone, there's these natural progesterone lozenges that you could take. I've tried this with a few patients. I must say that in this whole thing, I haven't had much success in terms of really having patients who have like very regular cycles. So it's actually quite difficult sometimes to know exactly when to start taking these medications a couple of days before ovulation if they have irregular cycles. So that can actually be quite a problem in real life. But if there are people who have very regular cycles, and then it's quite easy to target these areas, and then it can make a big difference for them. So I've had some patients where they just take an extra dose of their own medication around the times when they're vulnerable, or the clobazam, and it has worked. Some people can take continuous oral contraceptives sometimes if they're more vulnerable around the times of the menstrual cycle, like of the actual menstruation. You could take continuous oral contraceptive for several months, and so then at least you go several months without even having a period, and then you kind of have less seizures overall. So you might just have a period every 3 months or 4 months instead of every month, which can work for some people also. There's some experimental kind of hormonal therapies undergoing research in the States, but these are experimental chemicals, and there's no studies going on here in Canada right now on this, so there's not really any access to those because I've already inquired about a few patients. But the biggest step is to actually find out if it's regular and if there really is a relationship, because I find when you actually map it out, it usually actually becomes more complicated, but it's still worth doing and trying. Okay, now the other component I had said was that the epilepsy or the medications themselves could affect the menstrual cycle. So instead of the seizures being affected by the cycle, the seizures affect the cycle. So one of the ways that this can happen is by the seizures, the brain activity actually affecting the pituitary gland and your hypothalamus, which are in your brain, which are it's sort of like the first area that starts stimulating the hormone production in the rest of your body. You can also have an effect on the ovary of the medications and of the hormones in your body that can be affected by the medications. So I showed this diagram last year, but this is a better one that I found this year. So there's the hypothalamus and the pituitary gland, which are in your brain. And what this diagram was meant to show was that here is the temporal lobe. For example, people with temporal lobe epilepsy. Temporal lobe, this is the hippocampus, which is where a lot of seizures from the temporal lobe come from. And you can see from this diagram that it's actually quite connected to this area of the brain, the hypothalamus. There's sort of a whole system called the limbic system, and all these structures are connected. So activity in that area of the temporal lobe could definitely have an effect on the hypothalamus because they're very interconnected structures. So that's sort of one of the kind of reasons why we would think that the seizures themselves could affect your hormonal production by affecting the hypothalamus in the brain. The hypothalamus then stimulates the pituitary gland. So these are the two brain structures. They secrete hormones. In this case, when we're talking about the ovaries, this follicle-stimulating hormone and luteinizing hormone. Anyway, you don't have to remember these names. Anyway, they secrete the hormones that then stimulate the ovaries to produce the eggs. To release the eggs. So the point is, I'm just trying to say that there is structures in the brain that are key to controlling the hormonal environment of the ovaries. And these structures in the brain are very connected to areas that produce seizures. So you can see how they could interact with each other. Okay, so all that to say that women with epilepsy have a higher incidence of problems or dysfunction of the menstrual cycle than the general population. And it seems that women who have more seizures, so more than 5 seizures a year, tend to have more of these issues. So this is again some evidence that the seizures themselves might play a role in the hormonal dysfunction. Also, women who are on more than one anticonvulsant medication, so if you're on more than one anti-seizure med, you seem to have more of a chance of having problems with the menstrual cycle or other fertility issues and reproductive issues. And again, it's all more common with women who are on valproic acid. I think I already kind of mentioned this before. The women with epilepsy tend to have more cycles where they don't ovulate, both for generalized epilepsy and for focal or partial epilepsy. And again, valproate tends to have, if you're taking that medication, more likely to have cycles where you don't ovulate. And anovulatory cycles could make it more difficult to get pregnant. And as I mentioned before, may make it more likely for you to have more seizures. So probably not the best thing. Polycystic ovary syndrome also is associated with having a state where you don't ovulate as much, like you have regular cycles where you don't ovulate, as well as a combination of that and having a relatively more testosterone in your system compared to estrogen than usual. So people might have symptoms such as increased facial hair, acne, or hair loss. So this combination of symptoms could mean that you might have polycystic ovary syndrome. And again, that's associated it's 4 to 11% of the general population, and women with epilepsy 10 to 26%. So there is a significant increased incidence of that. And like I said, it could be related to the brain activity itself, affecting the hormonal structures in your brain. Or it could also be related to medications, and valproic acid has a high association with this. Again, what's good if it's related to the medication, then it is definitely potentially reversible if you come off that medication. So if you have symptoms like this, it's worth discussing with the doctor, especially if you're on valproic acid, because it definitely might be worth considering changing medication. But again, it all depends on your particular situation and your seizure control. I sort of already said this already. Yeah, okay. Yeah, so in order to prevent this, I mean, what we're really trying to do now is trying to avoid this medication, valproic acid, in young women. Because it's a problem in terms of fertility, weight gain, polycystic ovary syndrome, and in terms of effects on the fetus if you're pregnant, which I will get into later. So the best way is to try and avoid using it if you can in a young female of reproductive age. But sometimes you can't, because it is a very good medication for certain types of epilepsy, such as juvenile myoclonic epilepsy. And you may have to take that medication, or else you might just have too many seizures. So sometimes it's difficult, but if you can, it's probably good to avoid it if you're female. And again, in terms of hormonal dysfunction related to people with epilepsy, there's an incidence of having earlier menopause in women who have epilepsy. Again, usually when you have a lot of seizures, and basically the earlier it happens earlier, the more seizures you have, type of thing. And also if you've had many anticonvulsants that you're taking in your lifetime. Sometimes menopause can help your epilepsy, sometimes it can worsen it, sometimes it doesn't do anything. So it's basically a toss-up. 30% get improved, 30% worsen, 30% stay the same. So again, it's pretty unpredictable what's going to happen. And again, just like adolescence, it could be a transient thing as you're going through menopause. Seizure frequency might change during that few years and then settle down again back to the way it was before menopause after you go through that fluctuation. Yeah, so I kind of made this point that the seizure calendar and menstrual calendar, keeping those things together, are the important thing to do initially to try and see, is there really a relationship between the menstrual cycle and my seizures? And from there, you can move forward with the doctor in terms of trying to work around that to try and improve the seizure control. Okay, so now I will move on to the next part, which is contraception. So just briefly, this is kind of a very common question. Although I still see a lot of patients who are on the oral contraceptive and say carbamazepine, and I don't know, the doses aren't adjusted properly and it's still an issue. It seems like GPs should know this, but I guess it's worth repeating that if you're on any of these medications, there is a potential that they will interfere with the oral contraceptive if it's an estrogen-based oral contraceptive, because basically they stimulate your liver enzymes to metabolize the hormones faster. So the thing is that if you're on any of these medications, so this is Tegretol, Trileptal, Dilantin, topiramate is not as much, it's only on high doses, and phenobarbital. You need to have a higher dose of estrogen in your birth control pill in order to make it effective. And a lot of the birth control pills nowadays do not have this much because they're the low dose pills. So if you need to sort of review this with your GP or whoever's prescribing the oral contraceptive, because I still see patients where it hasn't been done properly, and because I always ask them, and then I see their pill package, and I'm like, no, it needs to be more. So, and I know even a patient who got pregnant on a lower dose, and it's not good. So if you don't want to get pregnant, so you need to kind of double check this. I mean, people should know, doctors should know. It's a pretty big question that we always get bombarded with in medical tests and everything. So I don't know why there's still mistakes being made, but this is important to keep in mind. And also, even if you are using the higher dose of the pill, you should always use another method of contraception just in case, because there still always could be fluctuations in levels of the medication, and you just want to be extra sure if you don't want to get pregnant. So these medications don't have an effect on the birth control pill. So this is Keppra, valproic acid. This is the new medication, Vimpat, lacosamide. These don't get used very often, Lyrica, gabapentin. So those are okay. Other types of oral contraceptive methods that could be used while you're on seizure medications, some patients would use Depo-Provera. This can be effective even if you're on the enzyme-inducing medications, the ones from the first page like Dilantin, carbamazepine. But the recommendation is that you get the injection every 10 weeks instead of every 12 weeks. This isn't widely published, and I had to look far and wide to actually even find this. So if someone was on Depo-Provera, they should probably mention this to their doctor, because I don't know if they would actually necessarily know this. It's not well studied, so it's sort of precautionary. It's not like there's been some huge study to determine the exact length of time between injections for women on these medications. Okay. Folic acid. Okay, so folic acid is another topic, supplementation of which is kind of in transition right now. For many years, it's been very standard that we just say every woman of childbearing age should be on folic acid, and for people with epilepsy, we usually put them on a higher dose, like 5 milligrams. That's what's been done in Canada, and usually in the States it was 4 milligrams, just because that was the biggest pill they had there, and 5 milligrams here. But the actual evidence for the dose of folic acid and which dose we should be giving is not that great. I mean, we know that we should be giving some, but to know exactly how much we need to give is not well defined. So the reason for recommending folic acid supplementation is that a large proportion of pregnancies are not planned, so half of them. And within the first month of development, so that before most people even realize that they're pregnant, critical development has already occurred in the fetus for the neural tube, so brain and spinal cord development. And folic acid has been shown to reduce the incidence of spina bifida, is one, and other neural tube defects. So because of that, certain foods in Canada are fortified with folic acid, like breads, and it's sort of recommended that all women of childbearing age, regardless of whatever their health problems they have, take 0.4 milligrams of folic acid a day. So this is what I had said already, that the neural tube develops in the first 4 weeks. And this is like the general recommendation for the general population. So every woman of childbearing age should be on this at least. And this is just the diagram of the neural tube. This is a better one than I had last year. It's basically, this is the fetus or the embryo very early on. It starts off kind of like a flat disc, and it rolls up kind of into a tube, hence the term neural tube. And basically the back, this is the back, so this will be the head, the tail end, and then we're looking from the back, so this would be the spine and the vertebrae. And so it kind of rolls together and kind of attaches, and it kind of almost like zips up and down. And spina bifida would be, say, at the lower part of the spine if it didn't close up properly. And then you can get other defects higher up involving the brain if it doesn't close up properly, which are even more serious. And could be, the baby might not live from those. So that's the spina bifida. That's basically what we're trying to prevent with the folic acid. Now then the question is, do women with epilepsy need more than 0.4 milligrams a day? Now the reason why we've tended to give more, like 5 milligrams, is because two of the more popular seizure meds in the past, so valproic acid and carbamazepine, have a higher risk of having a fetus or a baby with a neural tube defect like spina bifida. So valproic acid, again, is the worst. And carbamazepine is worse than not having carbamazepine in your system. And then the other seizure medications don't seem to have a higher incidence specifically of spina bifida. So it's really these two that have the higher risk of spina bifida. So because of that, everyone sort of just assumes if we give more folic acid, it's better and more likely to help. But we don't really have any proof of that. So there's a bit of a, but up to this point, everyone said, well, folic acid is safe. It's not going to do you any harm. So why not just give 5? More is probably better. But now there's been a little bit of evidence and research kind of muddying the waters and making people wonder, is it really safe to give these high doses of folic acid for the long term? Could it have any risks? So it seems that for patients who, if someone already has a colon cancer or a prostate cancer in their system, if you take a lot of folic acid, it might actually make the cancer grow faster. So that wouldn't be good if you had that in your system. So that's something to be aware of. So, but if someone has no colon cancer, if you take folic acid, it actually has been shown to prevent colon cancer. So really, it's a mixed situation, and it's complicated. So for sure, if you've had any history of a colon cancer and you're a woman of childbearing age, then folic acid would be something that might be risky for you. But for everyone else, it doesn't seem to be that big a problem. Again, another risk that has been theoretically brought up is a risk to the fetus. So, and I will try and not make this any more complicated than it has to be, but basically you have DNA, which is your genes and your genetic makeup. And then the chemical that is DNA, there's another chemical, there's methyl groups, which is sort of a chemical add-on that could be attached to your DNA. And depending on how it's attached to the DNA, it sort of affects how your genes get expressed or how they work. So it seems that folic acid affects how the DNA gets methylated, like how these add-on groups get put onto the DNA. So there's a theoretical risk that having more folate in your system can affect this in the fetus's DNA, and then might have some long-term effects in the baby's DNA and gene expression that we have no idea what it could be positive, it could be negative, but basically there could be effects on the fetus's DNA because of us ingesting a lot of folic acid. Basically, we have no idea if this is good, bad, if it's significant or anything. It's just sort of theoretical at this time, but last year it was in the news a lot and kind of raising all these alarm bells. So that's why people are now kind of questioning, should we really give 5 milligrams? Should we give less? Should we give just 1 milligram? And so I think, I'm not sure now, but I think one of the neurologists at the children stopped giving the teenage girls the higher doses of folic acid. And so there's a bit of a question around this. Were you going to ask a question, or you're just raising your arm? That girl was raising her arm. No, okay. So I'm sort of still not sure what the best answer is, but what I would say is that for sure a woman of childbearing age should be on 0.4 to 1 milligram. All the prenatal vitamins have 1 milligram of folic acid in them. So for sure, you should be taking that. Whether really you need 5 is kind of up in the air. I would say that maybe if you were on valproic acid or carbamazepine, it would make more sense that you would take the higher dose, because those are the ones that have the bigger risk of the neural tube defects. But whether or not everyone really needs to be on 5 who's a woman on a seizure medication, it's still a bit of a debate. Probably no harm done, but we don't really know. But at least 1 milligram is what I tell people, at least be on 1 milligram if they have concerns. And maybe people don't have to be on 5 unless they're on valproic acid or carbamazepine. That's just my sort of conclusion. It's not written out there anywhere. All that's written as an official guideline says that women should be on 0.4 to 5 milligrams. So it's a wide range, and no one knows the exact dose if you're on a seizure medication. Okay, pregnancy. I'm going kind of slow, so I might have to speed up here. Okay, so epilepsy is not a contraindication to pregnancy, and that most women with epilepsy who get pregnant, 90% of the time, everything is fine, and the baby's fine, and the woman's fine, and the seizures didn't go crazy, and everything was good. There are, of course, some increased risk of spontaneous abortion in women with epilepsy. And then there's sometimes some risk of seizure control changing when you're pregnant. So seizures might get worse, seizures might get better. But what it looks like is that basically if you had good seizure control in the 9 to 12 months leading up to pregnancy, then you're probably likely to stay well controlled during pregnancy.